that whenever he exposes himself to this benign looking plant, ragweed, that his eyes become itchy and watery, his nose is runny, and he's generally miserable. You don't believe him at all, but fortunately he's actually brought some ragweed with him, carefully packed away so as not to cause a reaction. And there in your office, he pulls this ragweed out, exposes it to his face, and before long he is a wreck. You're in disbelief, but you've accepted it, you've seen it, and you decide to write this up for your peers because it's unheard of. Turns out you're the first person to record a description of hay fever. The year again is 1819, and really a half a century later, it was epidemic. And it was largely attributed to urbanization. Now, incidentally, the term allergy wasn't even coined until the 20th century. Actually, same with anaphylaxis. So there's reports of anaphylactic reactions to wasps dating back to the pharaohs, but allergy is a new phenomenon. It's a new modern phenomenon. Now, the urbanization piece, we can look at this history and start to tease out important sort of historical antecedents, but antecedents that are significant to us today. And one of the big ones, of course, is toxins. All of my allergy patients, anybody on that bias, I'm thinking about a background of toxin exposures. Now, it isn't necessarily that they're currently under active exposure to mercury. It doesn't necessarily mean you need to get in there and do an aggressive detox protocol, but you need to consider it as part of your overall functional approach. Consider it in history. You might need to do some laboratory workups, and you'll do some lifestyle changes around it. Be it moving towards clean sourced organic produce or the lotions that they're using. Maybe they have amalgams you need to look into. But toxins act as adjuvants and really potentiate the allergic reaction. And I want to add in there, biological toxins. So, some of the mycotoxins that are spoken about often can potentiate allergies or present and flare allergies as well. In addition to toxin exposures or the urbanization, the lack of exposure to microbes is another big piece. So we've got this toxin underpinning, and we've got the hygiene hypothesis. And we can take the hygiene hypothesis even further to just a lack of biodiversity in our environment. So not just killing the microbes through antibiotics or less microbe exposure because of C-section delivery, but really in our environment, a drop in biodiversity is associated with increased allergic disease. And this was demonstrated elegantly in a pretty remote region of Northern Europe. It's called the Karelia, and there's Russia on one side, Finland on the other. They're both agricultural environments. So Finland has modernized considerably, adopted a more chemical form of farming, has removed much of the old growth forest. And they've got allergies. They've got and allergies akin to what we see here. Russia next door has almost zero allergies. And when you look at their environment, it's, consistent with an old, diverse ecosystem. They've got old growth forests. They've got a more diverse microbiota in their soil. Their diets are more robust. They're closer to their environment. And it's extraordinary in how it's reflected in the lack of allergic disease there. We need exposures to microbes of all sorts. Parasites, when we used to stoke hookworm infections, or when you look at other cultures where there's a higher exposure of parasites, allergies are non-existent in those environments. And that's because it attenuates the Th2 system. And interestingly, Th2 then goes on to balance Th1 and Th17 in this really extraordinary dance of immunological maturation, but also immunological tolerance and immunological balance. So again, here's a reference to the biodiversity hypothesis that's kind of supplanting and expanding the hygiene hypothesis. And it's interesting reading if this is an area of curiosity for you. Again, just pointing out the hygiene hypothesis, the biodiversity hypothesis, the need for exposure to microorganisms to balance our immune system and induce tolerance. And dogs. So for those of us who are dog lovers, pregnant moms with a dog in the home gave birth to offspring who just have significantly lower IgE. So kind of a cool thing, and an easy way to bring in some immunological balance. Another important antecedent is exposure to antigenic foods early on. In our country and in other Western countries, we've generally taught that we should avoid exposing our children to antigenic food when they're little, when they're infants. Wait to bring it in. And classically, this was peanut, right? But we could look at other countries, actually. The data have been there. I mean, looking at Israel, the rate of peanut allergy is so much lower than ours. And finally, we studied it here. And in 2015, the LEAP study was published. And that's where they showed early introduction to peanut-containing food led to a reduction, an 81% relative reduction in the development of peanut allergies. And that's changed the way that we practice. So this was the first study to come out, the LEAP study in 2015, and then that was followed by the EAT trial out of the UK. The EAT trial just showed early introduction of antigenic foods. So around 4 months, we're introducing antigenic foods. And in the whole study population, there were about 500 in the study group. They didn't notice anything significant, but when they did a subgroup analysis, they did notice that infants sensitized to more than one food at enrollment, so that is they have some IgE measurement, but no clear clinical reactivity, developed less food allergy than in the control group. And that was also, they also saw a similar kind of reduction in food allergy in those infants who had moderate eczema as measured by the SCORAD. Same in the EAT study also, early introduction of gluten, very early, again, 4 months, led to a significant reduction in celiac disease. In the control group, again, about 500 in each group, 7 developed tissue transglutaminase enzymes by the age 3. And in the study group, there were no celiac infants identified at all. Not that this is a conclusive way to avoid it, but it's something to really think about. We do, in our practice, recommend early introduction to vulnerable patients. Patients, I mean, obviously you're going to stratify for risk. If allergy has been established and if it's a severe allergy, you're not going to move in with micro exposures. But there are products available now where there's maybe a gram of the antigenic material. So it's a package of top antigenic foods providing just a micro amount of each, and you can deliver those. You can have that as part of the food to infants early on. And, you know, it appears like we've had some good success. Genetics, you know, single nucleotide polymorphisms are by definition ubiquitous. And we've evolved with them, we've survived them. Generally, they don't influence us greatly. But when you've got the collection of antecedents that I've just described, these mutations can become significant. So in this case, we're looking at kids with a glutathione transferase mutation. And when they grow up in a polluted environment, their risk for their increased incidence of allergic sensitization is high as compared to kids without the mutation. Antecedents, triggers, and mediators involved in food allergy. I've presented this slide to you earlier. This is a useful tool to just have at the ready when you're taking a case from, in a patient who's on the allergic continuum. This guides me as, to what I want to do as far as my treatment plan, my interventions, and just really understanding history and where I need to put my focus. Most people with allergies have leaky barrier. In fact, sensitization to an allergen requires a leaky barrier. Most commonly, we're looking at the gastrointestinal tract hyperpermeability, but skin can also play a role. Nasopharynx or oral mucosa can also be a piece of the sensitization process. Dysbiosis is de rigueur, again, generally gut, but it could be elsewhere. Bacterial fungal dysbiosis, small intestinal bacterial overgrowth, the various medications we're familiar with that damage the gut or inhibit acid production, et cetera, all can, or damage the microbiome, can all usher in allergies or worsen allergies. We often see other non-IgE food reactions in people with IgE allergies. So you might see some IgG alone, or you may see some non-immunological intolerances layered in. So somebody who's got classic IgE allergies, you might see in a very damaged gut histamine intolerance. So, keep an eye open for those cross reactions. In a patient who comes to me with seasonal allergies, I'm generally looking for cross reactions, and I'm often finding them. Nutritional deficiencies, especially nutrients involved in quenching inflammation or improving tolerance, you'll see oftentimes insufficiency, commonly vitamin D, maybe magnesium. If you're measuring fatty acids, you'll see low omega-3s. Stress can absolutely turn the volume up on allergic disease via a variety of mechanisms, from inhibiting stomach acid to altering the microbiome, to just, chronic cortisol, sort of blunt toxin exposures, as I've talked about as well. Our patients will respond to the 5R approach that you're familiar with. I've also created a new, just for the sake of simplicity, a new 6R, the 6R allergy approach that I call it, to just help summarize our approach to treating allergic disease that in practice has really done quite well. Folks with allergic disease come to you symptomatic. They come to you pretty miserable. And so reducing symptoms, out of the gate is important. Obviously, if they've got asthma, they need to be maintained on whatever medications is doing that for them. You can't stop an inhaler. Functional medicine has good success treating asthma. So you'll often find that your patients will, over time, no longer need them or use them much less frequently. But palliation for those with allergies is essential in my experience. And I'm thinking of one case in particular. A young woman with severe hives, worse at night, wasn't sleeping. And so she just simply needed Atarax at night while we did, or hydroxyzine at night while we did the underlying work to identify the cause of the allergies and, the cause of the hives, and to just treat her appropriately until she no longer had them. You want to remove. So you want to identify and minimize the antigenic load with diet and lifestyle changes. Think about toxin exposures. You want to replace with anti-inflammatory interventions at the right dose. Again, my cheat sheets at the very end will show you that. Oftentimes we're going higher with some of our interventions than you might normally go. The microbiome needs to be balanced. There's just no doubt about it. This can be with probiotics, with prebiotics, with fermented foods, but also think about the environment. Again, think about getting out into the natural environment, digging one's hands in soil, getting a puppy, or I kid, but maybe some people will go for it. But just thinking about the Russia-Finland study, getting beyond just popping a probiotic pill in the morning to actually an environmental change. We need to repair barriers, and we need to rebalance. A lot of folks on the allergy continuum, respond easily, readily. They may respond secondarily to a functional approach. So they may come to you with an entirely different condition, and as a consequence of a systems approach to whatever that original complaint is, their allergies are resolved. You'll actually see that quite a bit. Many are resolved with a general functional approach plus some maybe specific allergy interventions, and then some of our patients require extra sleuthing. And so I want to present cases from each of these. I'll start with a straightforward case, one that you'll definitely see in practice, I think, if you haven't already. This is a 45-year-old female. I'm in the East Coast. This woman is a lawyer and a mom. She's very busy. She commutes into the city, and she wants to, she just really wants to be high functioning. She's active in spin class, etc., or at least she was. But she's got this knee pain. She's got this really debilitating knee pain. You can see it, feel it, warm knees, kind of boggy. She doesn't have a lot of energy, no great surprise. She isn't sleeping. She's got some PMS. She's not losing weight as she thinks she should. And again, she's got a really high stress career. She's also a mom. In her history, she tells me that she's got severe allergies, seasonal anosmia. She can't smell. She completely loses her sense of smell. She's got hives really quite regularly. She doesn't know what the trigger is, doesn't really care. Sinusitis 1 to 2 times per year, requiring antibiotics and steroids. She has a history of childhood allergies and hives. She's, again, received antibiotics and steroids for sinusitis. Now, when she presents to me, we're not in spring or fall, so she's not worried about her allergies. And again, she doesn't have sinusitis. She's not active with hives. So these are not her chief issues. She wants energy. She wants to lose some weight. She wants to take care of her knee pain. So what brought her to my practice is my chief focus with her. I do want to resolve her knee pain, improve metabolism, improve energy, but I'm also knowing and confident in that if I do these underlying functional approaches, if I take a full kind of cast the wide systems net, that allergies should respond to that. So I do a battery of testing and that guides me, but I'm really primarily working with a basic 5R with her. I get her on a clean eating, clean living program. We identify with some IgG testing. She doesn't have any IgE foods, but she does have some gluten and dairy and soy sensitivity. We drop the carbs a little bit. She's leaning a little heavier on the carbs, so we drop them down. I do a stool test, and not surprisingly, she's got some dysbiosis. She doesn't have a marked small intestinal bacterial overgrowth, but she's got imbalance. Do a little bit of HCl2 titration to help with digestion. Give her a probiotic blend, and do some gut repair with a DGL zinc carnosine and glutamine combination. Give her some EPA and DHA and some vitamin D. And then based on her other labs, we rotate in interventions. B complex, so she had a low serum B12. She also had a higher methylmalonic acid. What else? I did organic acids, and her formiminoglutamate was up a little bit, which indicates a need for folate. Her homocysteine was probably slightly above optimal. So nothing crazy, but indicating she needs some Bs plus her energy needs. Her likely, her adrenal, her HPA imbalance. She needs a little bit of magnesium as identified on RBC magnesium. DHEA was a little bit low. I gave her some progesterone for her PMS. Her progesterone was slightly low. Cortef. So I did a 4-point salivary and a cortisol awakening on her, and she was really pretty flatlined, enough where I thought I would start with Cortef and then move her over to some HPA botanicals like licorice and rhodiola and so forth. But I wanted to just start with a nice little modest dose of energy for her. I asked her if she wanted to start on doing some loading on quercetin and nettles and vitamin C for the allergy season ahead, and she didn't want to. After 3 months on the protocol, she's in high allergy season and she's fine. She hasn't had any. No sinusitis, no anosmia, nothing. Hives, she learned after trialing dairy. So we did a full elimination and then challenged, and she reproducibly developed hives. Knees are better. She's challenged with gluten and she thinks that that's it. So pretty straightforward there. She's lost 10 pounds. 2017 update, she's still doing great. And on a 2019 update, she again continues to do fabulously well. A lot of our patients will respond to a full general functional medicine approach.